I'm going to talk about the more traditional drugs that we've been used to dealing with over the years, and then my colleague Gail, who works with me, is going to talk about some of the newer novel psychoactive substances, so touching on some of the things like ketamine and legal highs. Okay, so we've got one of the little questions. Have you tweaked the answers there, Sabir?
The way you did it, I couldn't have asked a question. Yes, because that number that you wanted,
Yeah.
if I just put that number down, they'd all know what number it was.
Oh, I see.
Yeah?
Okay.
So that number is hidden in there.
Okay, I thought that looks totally different to how I've written it, but anyway. Okay, so what percentage of adults have used illicit drugs in the last year? So adults at this being 16 to 59.
Do you want to vote, guys? So we've had over 60 responses, so if you just move it forward and just wait.
Okay, so we've got round about, so between 25 and 50, and I think it is round about a third, I think was the answer I wanted, wasn't it? Yeah, so approximately a third in the no, I think a third was lifetime, I think it was 8.8%.
8.8%.
Yeah, so you haven't actually got it on your...
Do you know what I thought? I thought it said 88.
No, not 88, it's 8.8.
Okay. Very good research.
That was after she been to Smoky Joe's.
I'm stupid, guys. That's 8.8.
Right, let's see if we've done any better with the next one. Okay. Now, this is what is the commonest illicit drug. So I've said excluding caffeine and alcohol. So what is the most commonly used illicit? So do you want to vote? We should be all right. Okay, so move it on. Yeah, and you're virtually all right. So vast majority is cannabis. And I've got some statistics on that. And yes, you're right, followed by cocaine. So that's the second most commonly used drug. So these are the statistics from the crime survey for England and Wales, and they're fairly up-to-date statistics. So yeah, 8.8% of adults, and that actually equates to lifetime use of around about a third. Now, when you look at the younger population between 16 and 24, that actually increases to almost 19% in the last year. And interestingly, I think this is the first year that the drug use has actually gone up. There's been a downward trend, and it's just gone up again this year. In particular, levels of cocaine, ecstasy, LSD, and ketamine. And yeah, so cannabis 6.6% in the last year, cocaine 2.4%. Okay, so this is the around the trend. So you can see here we're actually just starting to creep back up, particularly in the younger age group. I think the purple one, the lilac colour there, is any drug in the adults, and the black one is any drug in the younger population. So it is going back up. So it'll be interesting to see how this pans out, really. Okay, and this is the proportion of users in terms of individual drugs. So the cannabis users are using fairly frequently. That's the kind of punchline there. So cannabis users over here, they're using more than once a month, and that's 40% of them are using more than once a month. And the other group who are using quite frequently are the tranquilizers. So I guess we're looking at your benzodiazepines in that group. Okay, this is very similar to the information that Gordon gave us earlier about the spectrum of substance misuse. So the same would apply, that you've got your non-hazardous users who may describe themselves as recreational drug users. Then you go on to your hazardous use, and these are people who are potentially putting themselves at risk of developing harm. Then harmful use, again, they are actually experiencing harm. So they're not dependent, but they're causing themselves physical or psychological problems. and then obviously dependents. So the dependents are a lot of the people I deal with, but as a whole service between Phoenix and Swift, we deal with the kind of whole range from hazardous down to dependents. So again, Gordon covered this, a very quick whiz through what is dependence. So the same criteria for alcohol goes for any drugs that potentially may be dependent. So I'm not going to go through those again. I think they're fairly self-explanatory, and I think you need to have meet at least 3 of those criteria. So a little bit about what happens in the brain. So just a small amount around what happens with dopamine. And obviously we know when with dopamine production, we learn the association between the behaviour that we've done and the feeling that we get afterwards. So the brain then makes those links, therefore driving us to want more. Obviously we all do things like eating in order to produce dopamine, but unfortunately there's drugs that are much better at it than food. And once you get into that kind of thing, then food goes out of the window, and you want the one that gives the maximum dopamine response. So there's a whole range of reasons that people get addicted, from the environment they're in to the individual. So obviously, for many of you, you will see whole families or whole communities where there's certain addiction problems. Many have had adverse early life history of childhood abuse. Many of them, and it's currently in the news about how many have actually been in care, have actually ended up suffering childhood trauma and subsequently go on to develop problems. How available the substance is, so as Sabir was saying about Smoky Sam's, and there's another one almost next door but one to Smoky Sam's, and you drive down in the morning and there's people hovering about outside, so it's very available, easy to get, and obviously they're not getting arrested for it. Individual factors, genetics can be important, in particular with alcohol. There's very good evidence, especially for males, that alcohol may well pass through the males in the family. Less good evidence for drugs. Personality traits, the kind of impulsive, risk-taking, and the kind of buzz they then get from using drugs. And also psychiatric disorders. We all see people who are trying to self-medicate anxiety, social phobia, depression, in order to make themselves feel better. Right, we're having another crack at this. So, which of the following drugs are Class A? So I'm not quite sure how we've done. I hope this one's going to work out. So, yeah, carry on voting. Four are ticked. Let's see what they are. Okay, shall we stop the voting? We've got 60. Right, cannabis. Cannabis is not a Class A, it's a Class B. It spent a little bit of time being a Class C, but then was upgraded again. Yeah, I would expect everyone to know there that heroin is a Class A drug. And 7% of you here knew that amphetamine, when it's prepared for injecting, is also a Class A. Ecstasy and LSD are Class A as well, which I think can be a little bit of a surprise for some. So, yeah. Okay, not bad. So, quick summary of them there. So this was way back from 1971, and it relates to some of the penalties people can receive if they find in possession or in supply of the various drugs. So obviously the Class A getting more severe penalties. Okay, so I just want to move on to go through some of the drugs individually and about some of the properties. So first of all, cannabis, that's a picture of the cannabis leaf. I'm sure a picture many of you are familiar with.
You had lots of that picture.
They
this morning.
would have lots of that. So it is derived from a plant, from the Indian hemp plant, and the active drug is THC, tetrahydrocannabinoids, and obviously that's the important bit in cannabis. And different preparations can contain differing amounts. So the skunk, this one here, which is the one that contains the most THC, so it does tend to be the strongest. And this is the sort that's grown more and more and has become more popular, and they use hydroponics to grow it, so artificial growing conditions. But yeah, the kind of more traditional 1960s, 70s and 80s being marijuana or resin would not be as strong compared to the skunk that people are smoking these days. And synthetic cannabinoids, which I think Gail will touch on, is even stronger. So people generally mix it with tobacco and smoke it in a roll-up joint, or you can smoke it in a bong, which is a type of man-made pipe. It can be used in food, I suppose, although it's generally not that popular. So why do people take it? Well, it makes them feel nice and relaxed, a little bit more sociable. Everything just feels a little bit nicer. So, you know, you've got your talkativeness there, heightened perceptions. On the downside, sometimes people might get a little bit jittery, a bit anxious, a bit panicky, even a little bit paranoid. And obviously for those who are susceptible to mental health problems, that can be much more serious. And there have been studies coming out recently that long-term cannabis smoking can impact on the cognitive function as well. So perhaps ability to learn for somebody who's still at college. There is also evidence to suggest people can get dependent on cannabis, particularly heavy users. So they're smoking more and more, they find that they can't cut it down, and they actually experience some physical withdrawal symptoms. So, moving on to amphetamines, locally known as whiz or speed. Fet, I mean, it tends to vary depending where you are in the country and what decade you're in. So, amphetamines are stimulants. They increase your energy, increase your confidence, generally make you feel quite good, quite lively and energetic. So although we all assume people take it in order to feel high, certainly over the last 30, 40 years people have taken it for a variety of reasons. Some of you may well remember it being given out quite readily to help people lose weight back in the kind of 70s and 80s. So it was a really good way of losing weight. But unfortunately, there were some side effects. A lot of people tend to use it orally, and they either rub it into their gums where it's absorbed, or they what we call bomb it, which is where they wrap it in a little piece of rice paper and it's straight down. There are areas, particularly around Barnsley, of high injecting areas, particular places like Goldthorpe and Thurnscoe. So for any of you that work out there, there tends to be a group of people, probably in their 40s and 50s, who have been big amphetamine injectors, and it is still really popular. So, what are some of the risks of taking it? The kind of things we tend to see that suggest they're using it is people coming in with lots and lots of scratches on their faces, on their chest, on their hands. They're agitated, they're scratching, they've got scabs. And if somebody's acutely taking it, you may actually see the jaw clenching as well. In terms of heart, you could get a raised blood pressure, raised heart rate, which obviously could potentially be dangerous. They also can be extremely agitated, and again, if somebody's got a propensity to mental health problems, psychosis, then they're, we're going to be more susceptible, so they may be extremely anxious and panicky. Obviously, when we're thinking about risks of injecting, we need to bear in mind bloodborne virus, and as Sabir was saying about people injecting frequently, some of the stimulant users will inject very frequently in order to keep getting that high. So there's lots of potential risks there. I don't know what happened to the heading there, but that's meant to say cocaine. So cocaine is another stimulant. It originates from the coca plant, which obviously is typically grown over in South America. And as you probably know, local people over there tend to chew the coca leaves to get a mild stimulant. We tend to get it in 3 types. The common type that I'm sure you all know is the white powder, which people typically snort. There's also freebase cocaine, which is where they've kind of slightly altered it chemically and you get little crystals that are suitable for smoking. And then the one that is particularly problematic, often in our heroin users as well, is the crack. So again, generally smoked. However, all of these forms can be injected. And I think in terms of the heroin users in Barnsley, mixing heroin and cocaine is quite popular, and they either call that snowballing or speedballing. So, and it's obviously much more dangerous to inject it together, so it's quite risky. So you get a very quick stimulant effect. It doesn't last very long, and unfortunately people want to continue using it. So they don't get fed up, they don't kind of get saturated with it. So they will go through a huge pile of particularly of crack, because it is so rewarding, I suppose. Okay, so just a couple of pictures. That's a picture of cocaine. So people typically put it in a line and snort it through some sort of pipe, or a £50 note if you work in finance in London. I think pipes are more common around here. And these are some examples of crack pipes. So typically the empty can of pop will be turned into a crack pipe, or an empty plastic bottle. So some of the risks. In heavy use, that there can be quite serious cardiovascular risks, and I suspect, this is under-recognised when people are admitted to the acute trust with a major cardiac event or even a stroke, and it's certainly thought that cocaine can lead to some of that. Obviously, we all know about snorting it causing damage and erosion to the nasal cartilage. And there's also emerging evidence of heavy smoking a lot of crack can cause something called cracked lung, which is basically damage to the lung tissue, and obviously breathing difficulties. Risk from injecting, as I said, it is actually quite dangerous to inject it, as well as all the bloodborne virus risks, the risks of DVTs, etc. The crack users or cocaine users tend to lose weight. Again, being a stimulant and people using lots of it, they tend to have less appetite and they do lose weight. So it's not unusual to see some of them looking quite thin. And there's psychiatric problems as well. So it is a drug that causes psychosis or paranoia, agitation. And I think there's probably, when people are using a lot of crack, you've got increased risks of violence as well. Again, there is good evidence that people can get dependent on stimulants, whether it's amphetamines or cocaine. What they experience is something we call a crash when they stop using it. And by a crash, we mean they become ultra sleepy, their mood dips, they've got absolutely no energy, and their whole kind of sleep and appetite routine is disrupted, and they can actually have quite serious low mood and potentially suicidal thoughts during that period. So they do need to be kept an eye on at that stage. And it gradually passes. The acute symptoms pass after a few days, and then it will gradually resolve over 2 to 4 weeks. So just to reiterate, really, if somebody has come off, just think about suicidal thoughts and the associated risks. some people get this kind of protracted withdrawal syndrome where, chronic low mood, depression, lack of motivation, and ongoing craving, very intense craving for cocaine, especially crack. And when somebody is in withdrawal, there's no particular prescribing regime that we can give. It is really about supporting them and maybe treating certain symptoms as they arise. So heroin, this is a picture of the opium poppy. Obviously much of the opium coming from places like Afghanistan, Burma, that, again, generally that part of the world. So morphine is extracted from the opium poppy. It's obviously, we all know it's the most amazing painkiller. And in the past, it's been readily available for us to buy to treat coughs, diarrhoea, in the form of kaolin and morphine. And you can still buy certain cough preparations with opiates in. In terms of its misuse, people refer to it as gear or smack. And generally they either smoke it on foil or they inject it. And obviously for Sabir showed you the little spoons that people heat it on to inject, but equally it can be heated up on foil and they inhaled from it from there. So in terms of this area, the average price is about £15 for half a gram, but again that varies. And out in the Durham Valley you tend to find people still sometimes buy it in ounces or bags, so it does tend to be a bit different. And some dealers will sell it as a package with crack, so that, £20 and you'll get so much heroin and so much crack. So again, there's some of the injecting paraphernalia. So why do people like taking it? Well, I think people describe the feeling of being wrapped up in cotton wool, that kind of safe, protected feeling. So all your problems disappear. You feel nice and relaxed, there's no worries. So you can imagine how people, particularly with problems or difficult lives, how that will make them feel better, and they're just like going to continue to use it. And unfortunately, they very quickly get dependent and then develop all the physical withdrawal symptoms. And it's a good painkiller, so if anybody's got pain, potentially they could misuse. So the risks, obviously dependence, that in itself is a big problem. Injecting injuries, so abscesses, skin infections, DVTs, bloodborne virus as well. Overdose, it's fairly frequent that people accidentally overdose, particularly from injecting heroin. Dental problems, I don't know if you've noticed, heroin users registered with your practice often have very poor dentition, often have a lot of decay and so on, and often that's been neglected for many years. Mood disorders, people often feel very low in mood, depressed, disturbed sleep pattern. Criminal activity tends to be associated in order to fund it, and obviously there's family problems. It's very difficult living with somebody who's using heroin. It's incredibly disruptive. And then they become marginalised in the whole community in society. So there's many physical, psychological and social problems. So when we're treating, as Claire was saying earlier, they come in and have their assessment and obviously start the whole process. So what we want to try and do is manage the withdrawal symptoms, so take away the physical discomfort. We want to look at trying to keep them a little bit safer so that they're not injecting their groin and making the DVTs and leg ulcers worse. We want to get them to work towards abstinence, so that hopefully they will actually stop using drugs on top. And eventually work towards total recovery, where hopefully they won't have to have anything to do with drug services. So in terms of withdrawal, for some of them who've got big habits, it can occur very quickly. So, 6 hours, 12 hours is not that unusual. And that peaks the sort of 1.5 to 3 days. So you can imagine during a detox, that's your worst time. Methadone is a much longer acting drug, which as is buprenorphine. So your typical opiate withdrawal symptoms, some of them you can see the nice big dilated pupils. Sometimes they yawn in excessively, and it's probably not because you're boring them, but because they just can't control it. Nose might be running, eyes running, goosebumps. So there's lots and lots of stuff that you can actually see. And then all the agitation, the insomnia, the anxiety, and the gastric disturbance as well. So diarrhea and vomiting can be quite difficult, unpleasant. So in terms of how we treat the acute withdrawal, they can be prescribed a methadone as a reducing regime during a detox, or alternatively buprenorphine. And there's actually quite a lot of evidence that buprenorphine works better during detox, or Subutex. And interestingly, off what Chris was saying earlier, we used to have people saying, I want branded Subutex. And I think now about 18 months ago we said, none of you's having branded, you're all going on generic. And there was a lot of arguing went on for a number of weeks, but they now are all on generic buprenorphine. So, you know, I think eventually they got the message and they stopped arguing about it. Lofexidine is another drug we use during detox. So when people are having an opiate detox, they're usually supported by the nurses and recovery navigators who will be either seeing them at Burley Court or in GP surgeries or going out to their home. So those are the kind of medications we might use. And as part of it, it's all part of a package. So we don't just prescribe without them being part of having key work in one-to-one sessions at the very least, if not group work. In terms of substitution treatment, we've got a lot of people on methadone. Probably in secondary care, probably about 75% of ours are on methadone, and the other 25% will either be on buprenorphine or the Suboxone variety. So Suboxone is basically buprenorphine that's been mixed with naloxone. And the reason the drug company did that was, particularly in France, people were crushing Subutex and injecting it in order to get a quick hit from it. So they mixed it with naloxone, and as soon as they injected that version, they don't get the buprenorphine bit, they get the naloxone, which is an opiate reverser. So they would basically go into acute withdrawals. So it's a deterrent rather than, it's the same thing. If they're taking it properly, it's the same drug, but it's about trying to make sure they take it properly rather than inject it or snort it, which is quite popular in this country. And then the final option is injectables, and we haven't got anybody on injectables anymore. The last person on injectables died, so we haven't got anybody on that anymore. So as you probably all know, methadone is an oral solution. They take it once a day, and they go on daily supervised consumption, which means they drink it in the pharmacy when they first start. And we gradually build the dose up until we get to a therapeutic dose. The therapeutic dose tends to be between 60 and 120 for maintenance. Some can manage on less, some need more, but that's your kind of average. And there is a lot of evidence to support methadone because we've been prescribing it 50 years now, so there's a lot of good evidence to say it works on some of these parameters. Buprenorphine and Suboxone, and we've been using that in England now, I think, for about 14, 15 years, and certainly in Barnsley we've been using it a lot for the last 10, 11 years. So it's a sublingual tablet. It does take a few minutes to dissolve, which probably slightly annoys pharmacists sometimes, but and the dose range for maintenance for them generally is between 12 and 16. That's where we'd want to aim at. For those that do come off prescription, we get them off methadone or buprenorphine, there is the option of looking at going on naltrexone, which is an opiate blocker. So this would then, if they're taking that, this would hopefully help them to avoid any other opiate use. And as we've said, there. It's all part of a package of care. So they all have key working. They've got to see the key workers as well as the medical appointments. So it's not acceptable just to come every 3 months and see a doctor. They've got to engage in the whole thing. Okay. So, any questions before I hand over to Gail?
Any questions? Any hands up?
Historically, there used to be a demand for medication implants, which I understand is available anymore. Certainly, I've patients who seem to be a good choice for that. I'd be interested in your view.
Well, naltrexone implants aren't licensed in this country. So in the past they have been available privately. There was a GP in Sheffield who I think's now packed in completely. But he used to put them in. I think now in order to get an implant, I'm not sure if you have to go down to London now, to be honest. I mean, I suspect it probably would work for some people, but unfortunately, because of its lack of licence, it's not available on the NHS. So the Australian studies have been really positive and they are really into it, but it's just never taken off here. And I think the way with the, finance cuts, I can't see that changing in the next few years, to be honest. So I'm afraid they'll have to take it orally, although apparently they're trying to develop a depot.
Any other questions? You know how Dr. Ashby was talking about sort of substances in food? BMJ, May 2014, they're putting cannabis into gummy bears. Yeah? Yeah. Anyway. Thank you very much, Dr. Ashby. Thank you.
Yep. We'll just figure it out. Okay. I'm terrified I'm going to trip over these and go flying, so I might just stand here to be safer. My name's Gail Smith. I'm in ST6 in psychiatry. I'm working with Dr. Ashby at the moment, and she's asked me to come and follow on the talk that she's just given you by speaking a little bit about the legal highs or novel psychoactive substances, to give them their Sunday name. Now, these are substances that we are seeing an increasing amount of in Barnsley. We have got quite a bit of a problem, and I think Zibby has given an excellent introduction as to what that problem might consist of, in part. I am absolutely sure that in primary care you're going to be seeing just as big a problem, or an even bigger problem, relating to legal highs and novel psychoactive substances as we are in secondary care, because, to be honest, they don't tend to come to us, and we'll go on to reasons as to why that might be a little bit later on. Now, Dr. Ashby's given a lovely detailed introduction into a lot of the substances that we do see used and their effects and their treatment. I can't do that in relation to these substances, the NPS substances, purely for the reason that a lot of that information does not yet exist in a form that we can use clinically. Towards the end of what I've got to say, I will give you a few references as to where you can go to find out more up-to-date information. But if we start off by just thinking, what are novel psychoactive substances, of which legal highs is just one group of the substances? Because really, this is an umbrella term and it covers a lot of different substances. What I've got on here is just some pictures of things that might be available and how different they look maybe to the pictures that Fleur put on of the sort of classical substances. For example, we've got up in this corner here spice, which is the generic term for synthetic cannabis. Now, when they make spice, they don't just take cannabis and put it in the packages. They have a number of different molecules. They take some innocuous looking herbs, which are probably what you've got in those little packets, and then they spray them with a substance that's been made in a factory or laboratory. So when you buy a packet of spice, you've got no idea which specific cannabinoids have been put in there. Herbal cannabis is usually THC and various concentrations along with other cannabinoids. The synthetic ones could be anything. This here, for example, this is a synthetic cannabis. You wouldn't know by looking at it. It looks like any other random white powder. You can get a hint sometimes if it's got a J number or a JWH number. That tends to mean a synthetic cannabis. But in terms of identifying, it's really difficult. They may or they may not show up on urine drug screens as a cannabinoid, and the effects of them are not necessarily linked to what we think of as classical cannabis type effects. They may be more stimulant, they may be more hallucinogen. It is a really difficult thing for toxicologists and us as clinicians to try and work with. On the other hand, you might get some other things. For example, this one in the middle here, Ivory Wave, it packages bath salts, and bath salts is one of the sort of euphemistic terms that is used for legal highs. Plant food is another one, quite sort of geographically based as to the terms that are used. This Ivory Wave was the focus of quite a lot of media attention. It was its effects were very much like a stimulant, and very many A&E attendances, and people became quite unwell with it. It again has undergone lots of iterations, which is another challenge with these substances. What you get in the packet one month may be different to what is in the same packet the next month and the next month. Often people won't know what they're taking. The other example is this one in the corner, the benzofury one, and that's your sort of typical research chemical packaging. It's usually sort of quite professional looking, sealed. It will have a not for human consumption label on it. It's often got chemical structure, pictures on it. Despite the name benzofury, it's nothing like what we would consider a benzodiazepine. It's because the molecule is benzofurans, and it's something of a different order altogether. So the definition that we have for these novel psychoactive substances are substances which have been designed to mimic the effects of traditional recreational drugs. They've often been specifically manufactured for that purpose, and because of our current manufacturing capabilities, we're in a position where anyone can design a molecule on a computer, send it to a lab and have it mass produced within a short space of time. The upshot of this is that we are clinical staff having to deal with a problem that we can really feel quite unprepared for. I certainly feel that in secondary care addictions, that it's really difficult to know where to even start with these substances. I've just put up a quick thing about the different names that tend to be used. This is just, I've blurred it out so that you can't actually see the different names of the different drugs, because the reason for that is because you make up a resource saying this chemical does this, and by the next day it's out of date. So everything is moving very quickly. You've got this in your resource pack, which is quite useful if you want to get a bit more of a continually updated source of information on these substances. It's quite pictorial. It identifies various substances that are in use and classifies them by the kinds of effects that people might be looking for from them. So whether it's a psychedelic effect, whether they want a stimulant, and it also classifies them as to whether they're currently legal in this country or whether they're subject to control. Now, the chap who's done up this, there's a lot of different forms of this drugs wheel that he's done up, and in different formats as well, so not just the names of the drug, but also the different kinds of effects. And it's well worth having a look on his website. It's all free to use, and it's quite a good resource to use with your patients as well. So I want to just introduce a little bit about the background of these, which is basically we need an effective treatment approach for them. These substances are changing the way you think about the job, whether it's addictions as a specialist or addictions in general terms. We've gone from a situation where we have a service that's built around a few substances, and originally it would have been heroin, it would have been alcohol, with a few others that have come in over time as well. And now we've got all of these new substances that we don't know what they are, and often the users don't know what they are. So how on earth do we develop the effective service for them? So this is some data from Europe, and it's on the website of the European Monitoring Centre for Drugs and Drug Addictions, and it's an infographic of how these substances have developed. Now, similar to what Fleur was saying, they do identify about 8% of people are using them. So that strikes me as a fairly high number. We know it's more in the younger adults, not entirely, but more so. And what I want to do is just pull out one graphic from that, which is this table here. And what this table shows is the number of new substances that the European Monitoring Agency have picked up. Now, these are not cumulative numbers. This is the actual numbers from each year, which is rising year on year. So last year they identified 101 brand new substances, and now they've got well over 400, heading towards 500, that are currently known to be in use across Europe. With that in mind, we can't look at having a detailed knowledge of everything. However, we can't ignore them, because what we can see is that when we look at our mortality data for published last year, we can see that the mortality where NPS was implicated is this one here, which is, it's about half the mortality related to amphetamines. So it's not quite as bad as that, but it's still a fair proportion. And the likelihood is that it is probably an underestimate, because we're not very good at identifying where these substances have been implicated. If we don't suspect something, then we tend not to ask about it. Again, you know, I'm a psychiatrist. Our Royal College published faculty report, 1 new drug a week. That's an underestimate. It's quite a lot more than 1 drug a week. One of the main focuses of this paper was that we need to actually widen our front door, so we need to find more ways of actually seeing these people, because a lot of them don't come to our service. I worry when I've got somebody in my clinic who's a heroin and crack user, and they say, I wouldn't touch those legal highs, they're far too dangerous. Because they do. Yet they're on sale and people are using them. If we're not seeing them, where are they going? They seem to be that they end up in places like sexual health clinics. I would imagine that a fair proportion will end up in primary care as well. Can we develop a protocol for symptom-based rather than substance-based approaches? Our government they were concerned enough about these substances that they commissioned an expert report, and the findings of it was that there wasn't anything like the decent evidence of the harms of these. From that, I did a little piece of work as part of a course I was doing, looking at, well, what are the effects that we are seeing? And I found that there's hardly any literature in the journals that talks about what the effects of these substances are. I did as detailed a literature review as I could find, and I found 14 papers out of the whole thing for this country. I was looking just at mental health symptoms, and I found that there was a lot of references. Now, these aren't frequency data, they're just how many papers identified the substances. Hallucinations, paranoia, anxiety, agitation, aggression, confusion, sleep disturbance. That's the acute psychiatric one. That's before we even go on to any physical complications. And certainly when I was working on the inpatient wards in Chesterfield, we had people transferred to CCU with intractable tachyarrhythmias and things. So, big problem, what to do about it. I'm just going to mention very briefly some resources that might help you in the primary care setting. First off, this paper is 3 years old, but it's still got quite a lot of relevant detail. I've put the reference up there for you if you want to go away and have a look at it. And it's really talking about the general principles. We've spoken about the brief interventions for alcohol, we've spoken about a bit about the harm reduction, and all of those principles apply exactly the same. We don't need to know an in-depth knowledge of each substance to be able to give a brief intervention. I hope I've already said that it will be pretty impossible to have that in-depth knowledge of them all, especially when people come up to you and say, oh, I just take whatever's on sale, which they do. A lot of it is common sense as clinicians. The same kind of history taking as we would do for alcohol, for other drugs. What are you taking? What are you hoping to achieve from it? What are the good things? What are the bad things of it? So certainly this reference here, there is quite a bit of information on that kind of thing that you'd maybe need to do. It talks mainly about methadone, GHB, GBL and ketamine. Things have moved on a lot since then. There's a lot more on the menu. If somebody's presenting with any of these drugs, we'd certainly say, you know, have a conversation with us, refer them in to us. We may not have a clear treatment pathway like we would have for heroin, for example, but we certainly do what we can. And some of the cases, you know, if you think about like GHB, GBL, you know, there are real concerns about the safety of that and about withdrawal from that. It's similar to like benzo withdrawal, it needs to be managed really carefully. So if you've got somebody who is using any of those substances, do get in touch with us. But what I thought was probably more useful to you is where do you go for further information? There are some resources available to you, and certainly if you want to know lots and lots of information, probably the best literature review that we've got at the moment is the Neptune guidelines, and I've put the website on the next slide. Now that is a 350-page document, so it's not bedtime reading, but if you are interested, and that's there. The drugs wheel we've mentioned can be useful to use with your clients, and this one on the bottom left is a website of the drugs meter, which is also an app that people can use on their smartphones, because often people don't want to come into services and seek help, but if they've got an app then they can look at that, and what it does is they put in their usage and it tells them, well, compared with most people, you're sort of really high user or whatever, and gives information around that as well. It can be useful as an aid. And the other one I put on there is the Angelus Foundation, and I put that on because I would imagine that in primary care you would also be in the situation where you'd be approached by friends, family members in particular, concerned about somebody's use of legal highs, and because they have caused really serious problems in the past. The Angelus Foundation was set up as a support group for family and friends. There's a lot of good information on there though about the different legal highs, and they do a lot of campaigning on it. So I'm going to finish there with just these links on there. They are on your handouts as well, and I'm willing to take any questions.
One question, if there is any.
And it was a whistle-stop tour.
And very last session, Dr. Gibbons talking about the abuse of prescribed drugs.